Yeah, hello everyone. So this is the part 2 of the thin endometrium evaluation and management. So I hope everybody has seen the part 1 where Sir has discussed about the evaluation part. So today mostly it will be on the management and it will connect all the dots that were just spoken about in the last class. Yeah, over to you, sir. You can start.
So I'll be sharing the screen. Okay. So what is important for people to understand as far as thin endometrium is concerned? Okay, we have discussed this in the last class as well. I'll just brief everyone as far as the management. See, people have this continuous question on how do we treat thin endometrium. Okay, so this class will only focus on that. So I'll come back to the three main causes which we have to think of. Okay, one is the de novo cause. This de novo cause is basically a uterine cause. Okay. Now, in this uterine cause, it means that basically the uterus is only such that it causes persistently thin endometrium. Okay. The other cause which we discussed is any form of an external cause, like this external cause affecting the endometrium. This can be trauma, which is happening due to DNCs. This can be Asherman. This can be radiation, post radiation, all these types of things. So nothing much can be done, but I'll come to that a little later. And the first which we should keep in mind is a ovarian cause. So remember, whenever it is an ovarian cause, your treatment is very, very, very simple. Very simple. Okay, you need to rule out low AMH. Okay, and you need to stimulate better. Okay, what I mean by stimulate better is that if you are aiming for monofollicular development, then you should try to go ahead with multifollicular development. Just keep that in mind. So if you have done letrozole alone, then your treatment of choice becomes to do letrozole plus HMG. Okay, this is an important thing which you need to keep in mind to rule out a thin endometrium due to an ovarian cause. The second thing which we should remember is that sometimes when we are preparing the endometrium using an HRT cycle, and if that has not worked, okay, then the simplest next option is to switch to a modified natural cycle where you are stimulating with letrozole. This is only for FET preparations, okay, where you have an iatrogenic thin endometrium due to the poor quality of drugs used in the HRT. In that, you switch to a modified natural cycle protocol, and that will take care of the ovarian causes. Sometimes what will also happen is that you have given a pre-treatment with GnRH agonist, and this pre-treatment of GnRH agonist causes severe suppression. And this severe suppression can also cause an iatrogenic thin ET. Okay, in that situation, the simplest of the things for you is to just wait it out for 1 to 2 months. Just wait for 1 to 2 months. Okay, and after 1 to 2 months, if you stimulate the patient again with a routine HRT without GnRH agonist, okay, then that will be a better formed endometrium. So just keep that in mind. The other thing which people should remember about an ovarian cause is that whenever you are stimulating the endometrium, the estrogen exposure to the endometrium ideally should be more than 7 days. Okay, so just keep this entire thing in your mind. This is your bottom line. Sometimes people give HRT for a very limited period of time, which causes the problem. Okay, coming to the external causes, it could be trauma, DNC, Asherman, radiation, and I, of course, forgot one very important thing in India, that is infection causing endometritis. Okay, please remember this thing. For all this suspicion, your treatment of choice is to do a office hysteroscopy. You can't really say that I will do it on ultrasound guidance. You have to do a office hysteroscopy for both these causes. If you have seen a cause, then you have to treat the cause. That means if there is a synechia, if there is an adhesion, then you have to do adhesiolysis. Okay, if there is DNC, I mean, if there is a post radiation, then you will see that the whole endometrium is completely blanched. If it is infection, you will see the infective focus. In all these situations, you are supposed to treat it accordingly. Just remember one important take home point. Okay, in any of this, that means after trauma, DNC, Asherman, if you have more than 20% endometrium which is viable, okay, if you have 20% endometrium which is viable on your office hysteroscopy, only then autologous stem cell therapy will work on it. Okay, for autologous stem cell therapy to work, you require 20% of the endometrium to be viable. Please remember, fortunately, okay, Ashray or whomsoever you believe in has clarified that endometrial PRP basically has no role. See, I do understand that for people who don't know how to do stem cell therapy, they will want to do PRP because that is a source of income. And that is also some treatment which they have to offer to the patient. Okay, but remember one very, very important thing, that PRP has been established to have no role. So if in case you plan to do some justice to the patient, then the best justice is going to be done by giving stem cell therapy to the patient. All right, this is something which you should take in mind about the treatment of thin endometrium. Not to complicate it further, I just wanted to show. Actually, fast forward this video because I want to show an important part in this video. See, this is how your cavity is going to look like when you have intrauterine synecdoche, when you are performing intrauterine adhesiolysis. First rule of this is to ensure that you are expanding the os of the cervix. Remember, that is your landmark when you cannot see a cavity. So obviously people are going to ask, when I cannot see a cavity, how can I predict if there is a viable endometrium? You don't have to predict it. You will see it. Okay. Another important point, people often message, I have seen calcification inside the endometrial cavity. What do I do? The treatment of choice of calcification is to excise the calcification. We have done something like this similar across the country and very recently in Bangalore as well. And that patient has started to develop menses. Okay, once the calcification is excised, just remember that if the calcification is excised, the patient will get into menses. The calcification predominantly occurs due to a fetal part remaining when you have done a DNC for second trimester especially, or it can happen due to a endometritis which undergoes calcification. Okay, so an infective cause which undergoes calcification. See, the initial part of creating the cavity is going to be very difficult when there is no cavity. So I am using the bipolar resectoscope by palpating the cavity. Okay, every time I palpate the cavity, I get a clue as to which area, okay, I can go and create a new cavity. And slowly, if you see, if I just fast forward this a little because it is all synecholysis, see, slowly, if you see, the synecholysis reaches till a point where we have virtually opened up the whole cavity. Okay, and once you open up the whole cavity, in a situation like this, please remember, it is not mandatory for you to go find and see the ostia. In severe Asherman, in severe tuberculous endometritis, you are not going to be able to see the os because there will be severe fibrosis over that os. What you are going to see is a cavity like this, which has some amount of fluffy endometrium which is remaining. And because more than 20% of the cavity has this type of endometrium, which is remaining. Okay, here you can see the endometrium close to a particular region. Okay, and you can see the os as well, honestly, on the left side. But when you have something like this, when you find viable endometrium, can you see that os? Okay, I think all of you can see the os, and I hope the video is playing nicely because here is the os for this particular uterus. In this type of a situation, you can go ahead, okay, and perform injection of autologous stem cells. Okay, now where do we inject the autologous stem cells? Just remember, whenever you have treated the patient, okay, I'll come to that in a little while. See this, just fast forward it a little more and you can see the end of the cavity is such a huge cavity, right? Huge cavity. This cavity is so beautiful. This patient conceived after this, okay, because the entire thing was opened up. The patient had infusion of autologous stem cells in a single setting as a part of this surgery, okay, and the patient did extremely well. Okay, there are some practical tips which you should remember. See that when you have treated for Asherman like this, when you have opened up the basal endometrium at so many places, the uterine contractility will pick up. Okay, and at the end of this situation, you can just put an IUI catheter and inject the autologous stem cells inside. Okay, so I'll come to that. That sort of concludes this video. Okay, but in that thin endometrium, I just wanted to mention to people that when you try to put autologous stem cells, I'll just show you the cavity. See, what you should keep in mind is this. Okay, if it is a cause which is the external cause, okay, and if I draw the uterus for you, Okay, if I draw the uterus on both of them, okay, and see, this is the endometrium. Okay, this is a de novo endometrium, and this is a little irregular endometrium because this is a cavity which you have opened up. Okay, now in the cavity which you have opened up, basal endometrium will be punctured at multiple places just by opening up the cavity. So in this situation, if you put an IUI catheter inside or an embryo transfer catheter inside and gently push it over a span of 10 minutes, the stem cell aliquot, okay, then it is very, very good. But if it is a uterine cause where the endometrium itself is thinned out, nothing much is present, that is the situation where you have to use a needle, which is a Botox needle predominantly, and inject it in the basal endometrium. Keep one thing important: once your needle goes inside, you should stop the pressure. Okay, the cavity should become empty, and then you should inject a little amount of that aliquot so that due to the pressure of the saline, it doesn't come out. It has to go inside. So inject inside 0.4 ml, 0.3 ml and hold. Don't take that needle out. Okay. Then take the needle out. Again, fill the cavity with water. Once you fill the cavity with saline, a new location will open where your needle will go inside. Again, let the cavity collapse by stopping the insufflation, irrigation, pressure, and the cavity will collapse and then inject. Majority of the times, people who inject PRP, they inject it on running pressure. So what happens is if it goes inside the basal endometrium, 80% of it will spill out just because of the pressure of the water or your saline irrigation or glycine or whatever you are using. And which is the commonest mistake in that even if you have prepared the best PRP, or PRP will fail. Okay. So keep that in mind, and any which ways PRP will fail because PRP is outdated. So forget about it. Okay. If you want to do something, you focus on doing autologous stem cells. There are a lot of fine points as far as autologous stem cell therapy to the endometrium is concerned. I think probably if Shilpa madam agrees, we might have a dedicated fertility masterclass on stem cells because that is a very important topic. And we have done a lot of these cases across India with fantastic outcomes. Okay, so I think with that, I finished the management presentation for stem cells. I mean, sorry, for thin endometrium. Please just keep this flowchart in your mind, divide it into three, and you will be able to treat it very nicely. I wanted to tell one important thing that when you have identified something as endometritis, that as a tuberculous infection or any infection inside the endometrium, you need to give antibiotic therapy for minimum 14 days. That is important. And also supplement it with probiotics. Please just keep that point in mind. Never give antibiotics alone. It has to be antibiotics plus probiotics. Okay, you don't need to do a second look hysteroscopy in that. You will usually see that the endometrial thickness will increase only by little. But the architecture of the endometrium, which is white and hazy, will start to become triple lined within 1 month or 1.5 months following any form of these therapies. Okay. Do not promise the patient that from 5 millimeter your endometrium will become 20 millimeter. No such thing is going to happen, even if you put the stem cells. Okay. Your thickness may or may not increase. It is the architecture of the endometrium and its receptivity which goes up. And ultimately, because of that, the patient becomes pregnant. Okay. So with this, I conclude. I shall be happy to answer 2 to 3 questions from Shilpa madam.
See, there are a few questions in the chat box. So they're asking if the stem cell is not working. When do you say that?
You will come to know within 2 months if the patient has not got menstruation or if the cavity has recollapsed and adhesions have formed again. Okay, you will come to know about that in 2 months. There are going to be occasions, approximately 40%, 50% of the patients in whom endometrial stem cell therapy is not going to work. And it is nothing to do with the preparation of the stem cells. It is more so to do with the technique of the hysteroscopy or the de novo amount of adhesions which are present. As I said, endometrial stem cells will work when you have at least 20% endometrium which is viable. If you don't have a viable endometrium, it was a completely obliterated cavity, you went and opened up the cavity, even if you put the stem cells, the possibility that it may not work is very high.
So what is the cost of stem cells? Somebody is asking.
It's variable. It depends on the number of aliquots which you have to put inside.
And do you need to do a HLA compatibility for these?
No, it is an autologous stem cell therapy. Patient's own stem cells are going inside the patient's uterus or the ovary when indicated. So there is no need to look at HLA. It is not an allogenic graft. It is an autologous graft.
So in MNC cycle, how much HMG you give with
We
letrozole?
don't give HMG in MNC cycles. To do modified natural cycle, we only use letrozole. HMG should not be given.
And is low dose HCG useful for thin endometrium?
People say it is, but I have not found any benefit. I would not really try to give low dose HCG and then do an embryo transfer inside it.
Okay, yeah, I think that's about it. Yeah, if HRT cycle, how much dose of HMG? Why would we use HMG in HRT cycle? Okay, yeah, anyway, that's about it. Thank you so much.
Yeah, I think there was one question. Is there any legal issue as far as using stem cells is concerned? So let me just address this. There is no legal issue in using patient's own stem cells in patient's own body. The guidelines state that you are not allowed to isolate stem cells, okay, and culture them. So any which ways, the technique for doing isolation and culture of stem cell is so expensive that a routine patient is not going to be able to afford it. Okay. So there is no question of legality as far as you are doing an autologous stem cell therapy. The only important thing is you should mention it to the patient that this is an experimental procedure. Okay. This is not, it's like PRP. PRP is a completely experimental procedure, right? But nobody takes a consent. Why? Because it is just platelets. You just need to draw it from peripheral blood. When you need to draw platelets from peripheral blood, you don't need a consent of declaration when you are doing a phlebotomy for blood test. A similar thing is not required in PRP. But stem cell is a bone marrow procedure where you are isolating marrow, as a result of which it is good to take consent from the patient. I do not use any tamoxifen in thin endometrium. My experience with tamoxifen in thin endometrium has not been good. I strongly recommend people to probably not use it. If there are case reports where somebody has done well, then probably somebody can use it. But I have a very poor experience with tamoxifen.
Yeah, I think that's about it. Yeah, thank you so much. This completes the thin endometrium. So there is part 1 and part 2, which everyone can watch it on YouTube if they want to see it again. So thank you, sir. Thank you for your time. Bye.